angle glaucoma on the quality of life due to activity limitation.
A very good morning to all. Thank you for providing me with this opportunity. I start with my topic.
Dr. Letitia, you can use the mic so we can better hear you.
Hello. I'll start with my topic, that is impact of moderate and severe primary open-angle glaucoma on quality of life due to activity limitation. So glaucoma is one of the leading causes of preventable blindness, characterized by progressive optic neuropathy and corresponding visual field losses. Problems which we encounter are the ability of an individual to perform vision-dependent activity which reduces. Different parameters such as visual acuity, contrast sensitivity, and field of vision are compromised. Routine clinical evaluation, it does not assess a patient's ability to perform routine activities of day-to-day life. So understanding the effects of glaucoma on patients' perception of disability and consequent limitations is important. Patient-reported outcomes and performance-based measures, they can provide a better idea about how visual disability worsens a patient's quality of life. Various lacunae in literature which we encounter are resource-scarce countries with huge patient burden. Hence, PROs are more practical. Glaucoma-specific instruments have been used to evaluate quality of life in glaucoma, but the literature remains deficient in studies exclusively addressing the impact in patients with moderate and severe primary open-angle glaucomas. This was a hospital-based cross-sectional study in outpatients visiting glaucoma services in a tertiary care center. 122 patients diagnosed with moderate and severe primary open-angle glaucoma as per the HAP criteria were included, above 40 years of age, on medical therapy or undergone trabeculectomy or cataract surgery 6 months prior to enrollment. Various exclusion criteria were noted and the patients were excluded as per the following exclusion criteria. Extensive history and detailed ocular examination was done. Intraocular pressure, central corneal thickness, and gonioscopy was done. Visual fields with CETA-FAST 24-2 protocol was used. Patients having visual field losses more than 33%, and patients with false negative and false positive errors of more than 20% were excluded. Now, 3 glaucoma-specific instruments, that is glaucoma activity limitation 9, glaucoma quality of life 15, and Viswanathan questionnaires were used. Questions were identified in all the 3 questionnaires. Detailed analysis was done. Scores for individual questions were analyzed, and statistical significance was noted for each. Mean age of the study population was 61 years with higher males than female. Now, this is a bar diagram showing mean score of all the 3 instruments, which correlated significantly with vertical cup disc ratio and perimetric mean deviation in both patients with moderate and severe primary open-angle glaucoma. Now, this is the assessment of activity limitation in glaucoma activity limitation 9 questionnaire. Here, all the questions pertaining to activity limitation degraded the quality of life significantly in patients with severe glaucoma when compared to the controls. Whereas, with patients with moderate primary open-angle glaucoma, only 8 questions showed significant quality of life worsening due to activity limitation. When we assess the patient's activity limitation in glaucoma quality of life 15 questionnaire, we saw that all questions pertaining to activity limitation in severe primary open-angle glaucoma were significant, whereas in patients with moderate primary open-angle glaucoma, only 8 questionnaires which are highlighted were statistically significant. Now, assessment of activity limitation in Viswanathan questionnaire. Here we can see that in patients with severe primary open-angle glaucoma, all the questionnaires had a statistically significant effect on the quality of life limitation, whereas in patients with moderate primary open-angle glaucoma, only 2 questionnaires, that is question 1 and question number 6, they had a statistically significant effect on the quality of life. The third column shows comparison between the progression of the primary open-angle glaucoma. Here we can see that except question number 1, all other questionnaires had statistically significant effect on the quality of life in patients with severe primary open-angle glaucoma. Now, moderate glaucoma, here we can see that in questionnaires 9 and 15, significant effect on quality of life was there in all the domains except for central and near vision. Maximum patients in moderate glaucoma responded to the question, do you ever notice that parts of your field of vision are missing? Vishwanathan questionnaire had limitation due to peripheral vision loss, which was the most troublesome. Now, in severe glaucoma, domain-wise analysis showed that activity limitations significantly affected the quality of life in all the domains in severe glaucoma in both the questionnaires GQL15 and GAL9. They had maximum responses to the question, do you ever have trouble following a line of print or finding the next line when reading? Findings from Vishwanathan questionnaire showed severe glaucoma patients have most significant worsening of quality of life because of involvement of the central and the near vision tasks. Thank you so much.
Thank you, Dr. Itisha, very much. There is a comment.
Thank you. It was a great presentation, and thanks for touching on the point of the quality of life of patients. I think it is very important aspect too when we deal with the patient, rather just giving medication and drops and just ask them, just use it. Just wanted to ask, what was your role in this study?
Sorry, sir?
What was your role in this study?
Sorry, sir?
What did you do exactly in this study? What was your part? What was your participation?
So I questioned all the patients as per the performers, and as per the patients who were coming in the questionnaire, we had the performers ready, and as per the inclusion criteria,
So you did data collection?
Yes, sir.
Data analysis? Were you involved in the analysis?
Yes, sir. I did a part of it.
All right, okay. Thank you. Okay. You fair enough.
Okay, thank you, Dr. Itisha. Thank you
sir.
very
Thank
much.
you.
Next presenter is Dr. Sumaya Mohammed Dasadi, and her presentation is about her case is thermal burn of the corn. Diagnostic presentation. Yeah, case presentation, diagnostic dilemma.
Assalamu alaikum. Good morning, everybody. I am Dr. Sumaya Saidi. I am senior resident in Abu Dhabi Ophthalmology program. My presentation today about a case that we saw during the on-call, and it was a diagnostic dilemma for this case. So we start. My patient was 37 years old, female, presented to the emergency department of Sheikh Khalifa Medical City with history of right eye painful swelling and proptosis for 3 weeks. This patient, her past medical history, she lost the vision in the right eye since 9 months due to retinal detachment. For this detachment, she underwent postplantar vitrectomy with scleral buckle for funnel-shaped retinal detachment. Post the surgery, the patient continued to have like on and off pain, on and off swelling, and according to the OR note, the surgery was complicated and was aborted. This is my patient. You can see the right eye, proptose, erythema, conj is injected, some scleromeria areas, cornea is cloudy, and there was a hyphema. This patient has no light perception in the right eye. The globe was very intense. IOP was unrecordable. Extraocular motility was restricted in all gazes. There is no fundus view, and the left eye was perfectly normal. So as we cannot see, there's no fundus view, we have to do an imaging. So we did B-scan. The eye was disorganized globe, no intraocular mass, and no vitritis. So what was the diagnosis? Our differentiation was, is it orbitocellulitis? Is it surgical induced scleritis? Is it a masquerade syndrome, even though she's a young 37 years old? So we did a further investigation. We did CT scan. So the right eye globe was, you can see from the picture here, it is deformed, periorbital thick-walled collection, intraocular hyperintense material. So we decided to admit the patient. We started with an IV antibiotics, topical antibiotics, and we started IV Diamox. And we added oral steroid on the day 3. So the patient was improving, but whenever we taper the steroid, her symptoms and signs recur. So the doctor decided to go for exploration and possible inoculation. And you can see from the picture that we did inoculation and sent it for histopathology. And the surprise came when the histopathology report came. It was diffuse cell melanoma with necrosis. The histological type was epithelioid cell melanoma. The whole globe was involved. Nerve shape margins are positive. So our final diagnosis was uveal melanoma. So we referred the patient to oncology for further investigation, metastasis workup, and management. Patient preferred to continue her management abroad in her country. So for this patient, patient initially had uveal melanoma that led to retinal detachment. Retinal detachment is a common presentation for uveal melanoma, most likely exudative retinal detachment, which is about 75% of the retinal detachment. Rarely they have rhegmatogenous retinal detachment. Vitrectomy can accelerate extraocular extension of the tumor throughout the surgical sclerotomy sites. For masquerade presentation is very rare with uveal melanoma, and there was ocular inflammation is an atypical presenting feature of necrotic uveal melanoma. There was one study done in the George Washington University for 450 inoculated eye. The study was by Fraser and Font. They found that 20 patients of the 450, they have ocular inflammation symptoms and signs, which account for 4.9%. It was episcleritis, anterior uveitis, posterior uveitis, endophthalmitis, panophthalmitis. And only one patient had orbital cellulitis as a presenting symptom. So orbital cellulitis is specifically very rare representation. So how uveal melanoma presenting with orbital cellulitis? So the hypothesis said that the tumor outgrows its vascular source, undergoes necrosis as a result of hypoxia, release cytokines and other inflammatory mediators, inciting inflammation and features mimicking orbital cellulitis. So in the literature, we found a couple of cases have unusual presentation of the uveal melanoma. This case report from Portugal for a 75-year-old patient presenting as an endophthalmitis and was treated for endophthalmitis, but the patient had recurrence of the symptoms and found to have metastasis uveal melanoma. Another patient, 55-year-old Caucasian, no previous ocular symptoms, no previous ocular problem, no medical illness, presented with left eye pain and redness. And the initial diagnosis could be anterior non-necrotizing scleritis. But in the dilated fundus exam, they found inferior retinal exudative retinal detachment with mass. And during the A and B scan, they found it is a uveal melanoma. So learning points, melanoma can present with retinal detachment and it should be ruled out before any retinal surgery. Masquerade syndrome and intraocular hemorrhage can hide a neoplastic etiology. Atypical inflammation which is non-responding to treatment should warrant a biopsy. Imaging techniques such as B-scan, CT, MRI can assist in making the diagnosis when there is a poor view to the fundus. So in conclusion, uveal melanoma is a rare ocular pathology, varies in presentation. Early detection can save sight and save life. Thank you.
Thank you, Dr. Sumaya, for a very interesting case. Any comment from the panel? Dr. Majdi?
Thank you for this sharing with the case with us. What do you think happened during the first surgery? Because I think this is the clue for everything that happens later on. Because you said she did retinal detachment operation and scleral buckle. Is that right?
I cannot hear you.
You cannot hear me. I will put the microphone away because the voice is lousy in here. Can you hear me now?
Yes.
I think the operation, the first operation, you said in the history, she had retinal detachment operation, vitrectomy, and scleral buckle, right?
Yes.
This is the cause of everything because scleral buckles mean suturing, right? So I hit the sclera I opened the tunnel for the tumor to spread.
Exactly.
Second thing, when you showed us the post-operative the picture of presentation, there was malignant melanoma passing through the arteries, which passed through the sclera. So again, it's from the anterior segment. When they open the anterior vitrectomy, probably they have a way of spread of the melanoma. And this is the cause of scleritis, and whatever you diagnose after that, it's not pure scleritis. It's like inflammation in the orbit, the whole orbit, because of the malignant tissue passing through the orbit. So I think meticulous history in these cases would have been diagnosed even without any investigation. Because why it was aborted, why they stopped the operation, they found out there is a tumor in there. That's why they closed. But they already had a passage for everything to pass through the globe outside. So this is again, should have been reported from the first operation, that this is a wrong operation, and she had tumor mass and should have taken biopsy. They were in there. Am I right?
Yes, you are right.
So this is completely like, I don't know, the first surgery should have been contacted, because this is like disaster. You're doing something, it happens in our university. It was diagnosed as retinal detachment. They never knew that there was it was a young child, and it appeared to be retinoblastoma.
Yeah.
But we took a biopsy, we sent it, they knew that's a retinoblastoma, and we saved the child. So the first surgery always can have a clue for what's going on. Thank you for sharing this case.
Most welcome. Thank you, Doctor.
Thank you, Dr. Majdi, for the comment. Next presenter is Lobna Khalid Salama. She has also a case presentation. Dr. Lobna, if you can talk in the mic so can hear you well.
Can you hear me?
Okay, go ahead. Thank you.
Okay, good morning, ladies and gentlemen. I'm Dr. Lubna, ophthalmology resident at Dubai Hospital. I have no financial interest. I'll just present today a case for a 3-year-old girl who came to a routine strabismus clinic in our hospital, with the family saying that she has a right eye outward deviation for 6 months. She is otherwise healthy with no family history of any ocular disease. On examination, this patient has a drop of vision in the right eye to 20/200 with normal vision in the left eye. She has also right eye leukocoria, abnormal Berknes, and right exotropia V pattern around 40 prism diopter, as we can see in the picture. On examination, we can see the right fundus photo. There is a large, white, creamy mass at the center of the macula between superior and inferior arcade, even reaching to the margin of the optic nerve. This is a B scan. You can see a light-up material at the center of the lesion, thanks to Dr. Hassan, who took this nice picture. Here for the optus photo, we can see the diameter is around 7 by 7 millimeter, with the left fundus in the other side, which is normal. Again, this patient came only by exotropia. We ordered for her MRI, brain and orbit. It was only confined to the right eye. There was no extraocular involvement. There was no intracranial lesion. Here, only in the right eye. What we can think, say, I didn't touch anything. Okay. Working? Yeah. What we can think the differential diagnosis for this patient? We can say that it should be like a Coats disease, advanced RUP she had before, exudative retinal detachment. Now I came in the clinic with the help of my mentors to break a bad news for this patient and telling her that this case is not surgical treatment for exotropia, it's not simple glasses prescription. This patient has retinoblastoma. This patient has exophytic type of a growth pattern. She has the international classification of retinoblastoma of a grade B. So let's talk a little about retinoblastoma. Where are we now in 2022? First thing we have to know, there are around 5,000 cases reported yearly, and the survival rate is around 50%. And some countries, they have zero survival because they have no treatment modalities and no specialists. The treatment modalities before the chemo reduction era, we have either surgical or radiology or chemotherapy. Today, we will talk about this patient treatment, the intra-arterial chemotherapy. Intra-arterial chemotherapy, we can say another names for super-selective intra-arterial chemotherapy or chemosurgery. What are the indications for this treatment? It can be used actually as a primary therapy in naive eyes or advanced diseases or bilateral cases, and even for eyes who failed the primary treatments. Advantages of this disease, first of all, it saves us a lot of eyes from inoculation. And we can see here in the diagram how much it dramatically drops from 2005 to 2014. This medication will be directly entered to the eye, delivered directly to the eye. In this COVID era, we avoided the systemic chemotherapy, which will cause a low immunity. Children who take this therapy, they will be admitted in the same day and discharged on the same day. We have 3 agents we are using in intra-arterial chemotherapy: Melphalan, Tubtecan, and Carboblantin. We have age-appropriate dosage for these treatments. We can see that every age there is a specific dose for this. They are giving every 4 to 6 weeks on 3 sessions. Now we can see that we go directly, we put the patient under general anesthesia, and then we go with biocatheter from the femoral artery right the way up till we reach the site in the internal carotid artery where the ophthalmic artery branch. And then we can use the microcatheter, which will go inside the ophthalmic artery, and then you have to make sure that you are in the right place, and now you can see you are in the right place, and then you can start your intra-arterial chemotherapy. This is the retinoblastoma. You started the treatment for 6 weeks, 3 sessions, and now it should be shrink of this vascular retinoblastoma. I move these pictures like before and after of the treatment. This is the anatomy we discussed. Remember that we have the microcatheter. They are made it very tiny, even smaller than the ophthalmic artery. It's 450 micrometer. We should remember that intra-arterial chemotherapy is a teamwork. We need ophthalmologist with a neurointerventional radiologist and ocular oncologist so we can proceed with this treatment. What are the challenges that we have to face in intra-arterial chemotherapy? 12% they had ophthalmic artery vasospasm or narrowing that we cannot even catheterize. Some people, they have the origin of the ophthalmic artery from the middle meningeal artery. So it's a different anatomy, different technique, and can be done. Okay, what do you need to do for this patient who took intra-arterial chemotherapy? There are blood tests you have to do routinely, ophthalmic examination, you have to call the patient every time, and you have to monitor retinal toxicity by ERG or fluorescein angiography. Now we have complication of this procedure. Mostly it can be systematic or a bronchospasm or groin hematoma, or you have ocular, mostly it will be biliauricular edema or hyperemia, and radiation exposure. Sometimes after a first session, you can have cataracts. Up to date, there are no report of death or strokes. There is no development of secondary cancer, and the systemic side effect of chemotherapy was not even there. This, our case, as we remember, this is the retinoblastoma. After 1 month of intra-arterial chemotherapy, it's a shrinkage, and that's after 6 months, very successful shrinkage of the tumor. So take-home message, please be careful at the clinic. Do not underestimate strabismus case. Do full examination. And this technique you have to consider for the treatment of retinoblastoma. Thank you so much. Special thanks. I just do my ophthalmology heroes, Dr. Hassan, I think here, and Dr. Hashimi, and my father.
Thank you, Dr.
Thank you,
Lubna,
everyone.
for a very nice presentation. We have a comment here from Dr. Ayman Madanat.
Dr. Lubna, that was an excellent presentation.
Thank you so much.
Beautiful presentation, in fact.
Thank you.
And I wanted you just to add a few things to your presentation. Number one, stressing the family history, because family history is important in retinoblastoma.
Yeah.
And in cases of patients who have inherited retinoblastoma, the cases is bilateral. So also I wanted you to show me the other eye and the examination of the other eye.
Yeah.
Otherwise, your presentation was excellent. Thank you very much.
Thank you. Thank you so much.
Thank you, Dr. Ayman. Any comment? Dr. Majdi?
Actually, this case was a total shock to the family because none of the family member all over the family, no one had cancer before. Never. No. Yeah.
Thank you for the presentation.
Thank you.
The only comment I have is the complication of the intra-arterial injection of melphalan. Because I've seen cases, I'm not doing this, but I've seen colleagues presenting, there are a lot of complications in children, especially, as you said, catheterization, abnormal presentation of the ophthalmic artery, sometimes wrong injection in the wrong artery, sometimes necrosis in the arteries. So there is a lot of complication. It's not that safe. I mean, it's progressing now. It's much more progressing.
Yes.
But again, at the beginning, I've seen a lot of complications. Children are having like necrotic tissue behind the eye, wrong injection, catheterization was not that advanced until now, but still a lot of complications. But it's growing up now that it's the best line of treatment in that kind of melanoma. Thank you.
Yes, it's a new promising treatment, and I think they are maybe trying to find different techniques.
Yes.
But regarding melphalan, the interesting thing that when they tried intra-arterial chemotherapy directly to the eye, they show that it's less complication than the systemic.
Definitely.
Systemic chemotherapy.
But local complication is still there.
Yes, then they do the balance, and they said, no, we will choose definitely the intra-arterial.
Thank you so much for the case.
Thank you all. Thank you.
Dr. Lubna?
Yes.
Yeah, here. I'm here, yes. So it's not about the case, it's about the way you presented. It was amazing, beautiful, and you took over the stage entirely. And
thank you. I was panicking actually inside.
the presentation was quite lucid.
Thank you.
The way you presented, I would like to compliment on that.
Thank you so much. Thank you all.
One last comment.
Dr. Lubna, can I have one question, please? Dr. Lubna? Hello? Can I have one comment? A very nice presentation. So I do retinoblastoma, and we have a high number of retinoblastoma patients. My question is, which group of disease you choose for IAC?
Yes, for the, let's say if you open trials, they are saying the best result in grade D and E. But you can choose any case and try it. If you're going for the chemotherapy, choose the intra-arterial chemotherapy for these cases because it will be less complication. But the most challenging things that you need integrated departments to work with you. It's not ophthalmology. You need a radiology, you need anesthesia, you need pediatric doctors. That's the most difficult thing.
I have more than 100 cases for IAC, The issue that Magdi Musa presented, that it's not simple. When you start early, things are going good. But when you get into the 50 or 100 cases, we have very severe complication of ophthalmic artery spasm during the procedure. We have to come out from the whole procedure. Did you encounter any problem with your interventional radiologists like this?
We had a struggle actually with the communication between us and them, the radiologists, because they didn't do these cases too much. So they are, like hesitating, too much hesitating, because not too much they do this technique.
Thank you so
Thank you
much.
for your question. Thank you all. Done?
Our next presentation by Dr. Barsha Jindal, central and peripheral contrast sensitivity in myopes.
Thank you.
Please.
A very good morning to all. First of all, thank you to the Myome Academy for giving this opportunity. With this, I start my topic on assessment of central and peripheral contrast sensitivity in myopes using Spieth-Richmond contrast sensitivity test. So what is contrast sensitivity? Contrast sensitivity is the person's ability to perceive slight changes in the luminance between regions which are not separated by definite borders. It plays a very important role in visual acuity, motion recognition, pattern recognition. And without contrast sensitivity, there's a difficulty in performing day-to-day activities like reading, walking, climbing stairs. Central contrast sensitivity corresponds to the macular areas and peripheral to the extramacular areas. So why do we need to give a special focus on myopes? Myopia is the most prevalent refractive error with the incident prevalence of 9 to 21% among the Asian populations. A reduced contrast sensitivity has been noted in myopes when compared to emetropes. And contrast sensitivity decreases with increasing degrees of myopia. Why does this happen? That myopics, they complain of poor visual function despite normal visual acuity. It happens because of the choroidal thinning and reduction in the choroidal perfusion, which reduces the photoreceptor metabolism. And the second reason is the neural deficit, which is caused by the prolate stretching of the retina with axial elongation. So how the literature is lacking? Most studies, they just focus on the central contrast sensitivity. And why do we need to focus on peripheral contrast sensitivity? Because myopes experience a greater decrease in contrast sensitivity in the periphery than emetropes when attention is deployed in the central vision. And there's no literature is available in the Indian population. Why do we need to choose Spieth-Richmond contrast sensitivity test? Because Spieth-Richmond contrast sensitivity test uses a spatial frequency of 0.4 cycles per diopter, and thus it works best for assessing contrast sensitivity levels needed for most day-to-day activities. Only one study has been employed in past in patients with various corrected errors, and no statistical significance was found between myopes, emetropes, and hyperopes. Ours was a prospective cross-sectional study consisting of 126 eyes from 50 myopes and 15 emetropes. Patients were divided into 4 categories, with group 1 consisting of spherical equivalent between 0.5 to 3 diopters, group 2 with spherical equivalent of -3 to -6, group 3 with -6 to -10, and group 4 is the control group with no refractive error. We took the individuals, healthy individuals between 18 to 70 years of age, and with the best corrected visual acuity of 20/50. Patients with history of incisional surgery or any cataract surgery in the past were excluded, or any of the patients with pathological visual impairment. So how the Spieth-Richmond contrast sensitivity is done? It is done using an online platform, that is www.sparkscontrastcenter.com, and each patient is given a unique identification number on a standard computer. A practice test is followed by a final test, and this test is performed uniocularly with habitual spectacle correction, and score and time for the final test is noted. So candidates are seated at a distance of 50 centimeters from the monitor screen, and they have to focus on central testing area, and when they are ready, they have to click that. Vertical square gratings, they appear randomly in one of the 5 areas for the duration of 0.3 seconds with a spatial frequency of 0.4 cycles per degree. At this point, the candidate, he identifies the area with grating, and he temporarily breaks the fixation from the central area to select the area with grating. Candidate fixated again on the central area and clicks on it to prompt the test to show the next image. And correct and incorrect responses, they are recorded by Sparks till the testing system determines contrast threshold in each area. So this is the computer screen. It's showing the setup of the Spieth-Richmond contrast sensitivity test. So the study consisted of 126 eyes with 96 eyes from 50 myopic subjects and 30 eyes from 15 emmetropes. We have found that there was a statistical significant difference in the total Sparks score and the score in the central quadrant when compared to the controls. No statistical significance was found between the groups in baseline, in best corrected visual acuity, intraocular pressure, Pelly-Robson score, Sparks score based on gender across the 4 groups. So now myopes, they experience a greater decrease in contrast sensitivity in the far periphery than emmetropes when attention is deployed in the central area. And retina of high myopes, it retains its normal integrity until the outer retina is compromised. As we have seen that our study, the candidates in our study, they have a uniform Pelly-Robson score of 2.3. Similar results have been found in a study that was done by Thorne and co-workers in 1986. We found a statistical significant difference in the total Sparks score between the 3 groups, thereby highlighting the importance of peripheral contrast sensitivity. No statistical significance was found between the gender and contrast sensitivity and age and contrast sensitivity. However, in previous studies, it has been shown that males and females, they have similar contrast sensitivity at low spatial frequencies, but with increasing spatial frequencies, males, they tend to have higher contrast sensitivity. So with this, we come to the inference that loss of contrast sensitivity in myopes may be suggestive of early stages of disruption of retinal function preceding the structural retinal pathological events. And there's a significant difference in the contrast sensitivity in patients with varying degrees of myopia, with decreasing contrast sensitivity with increasing severity of myopia, and assessment of peripheral contrast sensitivities is a very important adjunct to the central contrast sensitivity. The things which are lacking were we did not take the axial length into the account, and a longitudinal study, it needs to be done to see the progressive changes in the contrast sensitivity in myopes. Thank you.
Thank you, Dr. Rasha. Any comment from the panelists?
Thank you, Rasha. This is a very good study. But for myself, I would add something that would make your presentation even more interesting. It's a very interesting presentation. If you did an OCT to your patients and compare the results of the contrast sensitivity with the retinal changes, retinal layer changes, this would be an excellent plus to your study. Thank you very much.
Thank you, Dr. Ayman. Next speaker, Dr. Safiya Sulaiman, with a presentation, Atraumatic Iris Prolapse. They changed it. فاضل دقيقة ولا بعدها؟
Sorry for that. Assalamu alaikum. Good morning, everyone. My name is Safiya Al-Brashdi. I'm a PGY3 from the Abu Dhabi Ophthalmology Residency Program from SKMC. I'll try to stick to my time frame, so without further ado, the title of my presentation is The Zipped Coin Bag, and as you can see, it's a pretty interesting photograph. So I'll go quickly through my agenda. I'll go through the case presentation, the diagnosis, the discussion, and the literature review. So this was a 26-year-old male who presented with severe left eye pain for 1 day. It was associated with complete vision loss. His previous eye history that he had eye trauma in Pakistan and query surgery. We did not know what type of surgery he had. For the physical exam, on the right eye, he was 615. On the left eye, he was hand motion, which is the eye with the picture. The IOP was 11 and 52 millimeter mercury, respectively. As you can see, you can understand why he was in pain. He had an injected conch, DM folds, shallow AC, and there was obviously no view of the fundus. As you can see from this picture, with the injected conch, there is an absolutely occluded pupil. So the patient just came to us without a pupil. This is a slit lamp photo showing the shallow AC and the absence of pupil. So this is a case, a very rare entity of occluded pupil. It's actually occlusio pupillae. I did a lot of research on it until I found what it is actually. We were very confused when we were dealing with this case in the on-call. We did not know what entity this was. Upon more research, I found a diagnosis in a book called Ocular Pathology by Myron and Stephen Joseph. They described occlusio pupillae as a rare entity, fibrotic inflammatory membrane across the pupil, and sometimes occluding it completely. It can coincide with posterior synechiae, and if 360 degrees can cause pupillary block. So what's the difference between a secluded pupil and an occluded pupil? A secluded pupil, as you can see from the first picture, it's a fibrotic membrane that may attach the pupillary margin of the iris to the underlying lens, if phakic, or intraocular lens, if aphakic, if you had cataract surgery. It's resulting from posterior synechiae. It could be inflammatory and or uveitic causes. The second one is more similar to our case. It's an occluded pupil. It's also an inflammatory fibrotic membrane covering the pupil completely, so not just secluding it. It's presumed to be of the same causes. So what we did to our patient, we did something a little bit different. We tried to do a PI and we couldn't, so we did an iridotomy. We created an artificial pupil for the patient. There was a laser attempt to open an artificial pupil using YAG laser. Once we did the YAG, a gush of fluid came out. After that, the next day, the vision of the patient went from hand motion to 612. He had a clear cornea. We put him on maximum medical therapy of Diamox, Travatan, Cozapt, and Alphagan, of course. And we discharged him with 612 vision from hand motion and with maximum anti-glaucoma agents. This is the artificial pupil that we created that resulted with a gush of fluid from hand motion to 612 vision. So summary of the case, this is a patient that came with high IOP, a completely occluded pupil, which was bizarre to us. We've never seen anything like that before. An artificial pupil was made. We abided by maximum medical treatment for the high intraocular pressure, and there was restoring of the vision and IOP. This is a picture of before on my left hand and after on my right hand. So what we did differently is that we created an iridotomy or an artificial pupil using Nd:YAG. The only case that I saw where they treated occlusio pupillae either with PI and then either surgical or non-surgical pupilloplasty. So this is the only study that I found. It's from Canada. They treated occlusio pupillae as well as seclusio pupillae, but they treated it surgically, whereas we treated it differently. We did not even do a pupilloplasty. We did an iridotomy. We created an artificial pupil, which has not been done before. So to conclude my presentation, this was a very bizarre case in my on-call. I think if we shied away and referred the case to somewhere else, we wouldn't have had the pleasure of treating this patient. I like this quote by Steve Jobs. He basically said, innovation is the ability to see change as an opportunity and not a threat. And that was our opportunity and we took it. Thank you.
Thank you, Dr. Safia, for a very nice presentation. Any comment, Dr. Majdi?
Thank you for the presentation. Thank you for sharing this case. Do you think this, it looks like a pupilloplasty, you did a new pupil, but wouldn't be occluded again, I mean, after some time, because you didn't know the cause of occlusion, right? It's like inflammation caused the membrane which closed the pupil. So would you expect that this can happen again and the pupil can be closed again?
So basically, from my research, most cases of occlusio pupillae happened because of an inflammatory cause.
Yes.
So I think, yes, it definitely could happen again for the patient, as an inflammatory process could be ongoing.
And you would do it again if it happens again?
Oh, that we need to innovate something else, I guess.
Okay.
That was temporary.
Thank you so much.
Thank you, Dr. Safiya, for your presentation. My question is, how I want you to tell the audience, how would you do your iridotomy using the YAG laser that large? It's important. Do you start with only YAG laser? Do you use the argon laser before? How would you do it?
So I don't have much knowledge on this, unfortunately. I was lucky enough to have my consultant.
If you don't, let me tell you about it.
Sure.
If you want to do a large PI, you don't do it with the YAG laser alone. You cannot. You will have bleeding. The first of all, you do a 300 or 500 spot of YAG of argon laser, where the tissue will be stiff, and you will decrease your bleeding. Then you start using the neodymium YAG laser to open this. Just to tell the audience about it.
Thank you.
Thank you very much. Our next case presentation by Dr. Najla Hassan Salim. That's our last presentation.
So, good morning, everyone. My name is Dr. Najla Al-Ali. I'm graduated from Dubai Residency Program, working in Dubai Hospital. And today I will present a case of acute eye pain and proptosis. So, a 15-year-old boy referred from private clinic to Dubai Hospital complained of left eye pain and proptosis, diplopia when looking laterally and inferiorly. On examination, the vision was not affected. There was a restriction of the left eye in the lateral gaze and in up gaze. Other examination, there was an axial proptosis with a superior orbital fullness. By measuring by Herter exophthalmometer, it was 21 compared with the 16 in the right eye. Conjunctiva, there was an injection mainly along the muscle insertion laterally. Other examination was unremarkable. So our approach, we took a full history and it was an acute onset. We did examination, as we said before. Systemic review was negative. We did a basic blood investigation. It was all negative, so we ordered for this patient a CT with contrast. As we can see, the CT with contrast is showing a heterogeneous mass that cannot be separated from the lateral rectus, pushing the optic nerve superior medially. There was no bone erosion and there was a proptosis. The radiologist advised us to go further to do an MRI or to take a biopsy. This is another picture. We can see that it is intraconal mass, which is pushing the optic nerve. So our plan was to admit the patient for 3 days IV methylprednisolone and then to schedule the patient for excisional biopsy. Day 3, post-IV methylprednisolone, patient was feeling better. There was no relative afferent pupillary defect. The eye movement restriction is less, -3 in the up gaze and -1 in the lateral gaze. By Herter exophthalmometer, the proptosis was less by 19. It was normal color vision. Day 4, patient was scheduled for lateral orbitotomy with an excisional biopsy. As we can see, we started with an incision in the superior eyelid crease to expose the orbicularis muscle, the temporalis muscle, and to expose the lateral orbital rim. Then we used an oscillating saw to break the bone for further exposure to the intraconal mass. Sorry. Excision was, we made sure to do a clear and complete excision for the mass and complete hemostasis to prevent intraorbital hemorrhage that can happen, and we applied the drain. This is a picture of the mass which was removed by Dr. Nizar Hashimi, our consultant. Day 3 post-op, patient was feeling better. There was mild pain at night. There is an upper eyelid ecchymosis and edema. There was some ecchymosis in the conjunctiva. Clear cornea. The pupil is round and reactive. We made sure that the patient is okay. The wound clean, the dressing change, and the drain was removed. Patient was discharged on day 4 post-op, and the plan was to follow up in the clinic after the pathology report. So 10 days, the pathology report came as a small round blue cell tumor with a feature of embryonal rhabdomyosarcoma. So the patient was diagnosed with a rhabdomyosarcoma. We referred the patient for the pediatric oncologist. They advised to do an MRI to rule out any remnant of the tumor and to start radiation and chemotherapy. So briefly, I will talk about rhabdomyosarcoma. As we know, it's a rare childhood cancer with estimated 250 to 350 new cases per year. The male to female ratio, it is 5 to 3. The prevalence, it's the most common childhood soft tissue sarcoma. 5% account for 5% of all the childhood cancer. There is 4 pathological types: the embryonal, which is the most common; the alveolar, which is the least common; pleomorphic, and the bateroid. Usually, it presents with most of the cases with a proptosis, globe displacement, blepharotosis, conjunctival and eyelid swelling and pain. The management, either you take an incisional biopsy or you do an excisional biopsy to confirm the diagnosis, and you start the patient on chemotherapy and radiation. Of course, patient need a metastasis workout. The alveolar cell type have a good prognosis, 74% 5-year survival rate, and the embryonal, which is the more common type, have a 94% 5-year survival rate. Thank you so much.
Thank you, Dr. Naja, very much for presentation. Any comment from the panelists you have? Dr. Majdi again.
Thank you for the case. It's a nice one. I was talking to my colleague here, telling him it could be a rhabdomyosarcoma, but usually it's more aggressive than this. When we see rhabdomyosarcoma, it's really aggressive tumor, and I wonder how it responded to methylprednisolone. I mean, sometimes we do a test like giving steroids. If they don't respond, it means definitely it is a tumor mass. Otherwise, it's retrobulbar inflammation. So I wonder why it responded so quickly to the corticosteroid, because this is a negative test. Should be a positive test to do that.
Yeah, actually we were thinking of a dermoid when it was responding to the steroid, but that's the aim of the presentation, that it could be sometime not as we think. Yeah, the misleading, yeah. Thank you so much.
This was really a beautiful presentation. Sometimes the tumors, they respond because of the edema. The steroid decreases the edema. This is why you should feel slight improvement. It happens. But my question is that I want to elaborate on the pathology. You know that different, as you said, there's different types of retinoblastoma with different prognostic issue. I think the polymorphic is the worst, isn't it?
The polymorphic is the worst.
So what type of pathology was that?
This one was embryonal.
To elaborate more, to show us the slide of the pathology, and to elaborate more. This would make your presentation, it's excellent. It would, you will have a plus.
Thank you so much.
I want to thank all of the presenters for very nice presentations. You all did well, and if you give us just 5 minutes, yeah.
Do some comments while you do the calculation. I would like to congratulate the speakers. All of the speakers presented themselves very well in the podium. I know some of them presented for the first time. I would like to congratulate you all winners today. And I think this is a good opportunity for us. We will have a future great ophthalmologist presenting in our podiums. So next year you will be presenting in our podium, inshallah. Thank you all.
Can I make a comment? They were all great. I mean, even if for the first time, this is a very good because you know the first time you are shaking, you don't know what you are going to be asked, you don't know what the judges will say about you, but was great presentation. None of them disappointed us. They were all great, and I hope they are all winning. But unfortunately, we have to have one winner. So probably you are all winners, but trust yourself, do more or more, and I like the presentation. All of them were good. Thank you so much.
Well, we have a women ophthalmology session in the afternoon, but it was very heartening to see all young, bright, young female ophthalmologists in the EO session as well. So cheers to you and keep it going.
We didn't notice that they are all females until she mentioned that. And probably males are disappearing this year from the ophthalmology. All are females coming up, even in Egypt, by the way. Most of the young ophthalmologists are females. I don't know why, but we are going to do a study about that.
I think Dr. Ala have a comment.
Yes. Thank you, Dr. Najla, for this nice presentation about the rhabdomyosarcoma. I want to stress on one point, that is the methylprednisolone is not improving the tumor itself. It's improving the inflammatory process which is associated with rhabdomyosarcoma, which is commonly presented with orbital cellulitis-like presentation. So the double vision is an edema of the extraocular muscle, is an orbital cellulitis-like. So the methylprednisolone improves the condition of the inflammation, and thus she goes simply to the mass without any inflammatory process to remove through a lateral orbitotomy. So it's a nice presentation, and I think this is the methylprednisolone who has done. Not treating the tumor, but improving the edema. Yes? Thank you very much. Thank you very much.
All right, okay, we'll wait for them. This is like a tense moment for the presenters. I would like to ask the presenters, is it your first time to present in a big meeting? So presenters, all of you the first time, not for Dr. Najla, first time? So all first time. So I know how honors, but not for you. Okay. All of you did very well. You presented yourself very well, and I think you have attracted the audience. Definitely the panelists, we were very interested, and we didn't miss any of your slides, so it was very continuous and excellent presentation. So that is also an excellent point for the judges to keep this in mind when they do the results for you all.
I had insomnia yesterday.
All right, who didn't sleep yesterday? Okay. How many times you practiced for your presentation? How many practice you presented the whole slides? You went through it. Oh yeah, you had the exam. So I know other people had the exam. Sumaya also had the exam. So how many times you practiced? It's a good skill to practice how to. It's a show. Like when you are sitting in the podium, remember this is like a show. It's like a play. And you know how to say the words and keep the audience attracted to your presentation. So it's not a bad idea to practice your presentation. Look at your videos. Know when is the important point that you should stop and attract the attention again to the audience at this part of the surgery. You need to focus on this. I think the result is out. All you passed the exam.
First of all, I would like to thank all the speakers. They are all nice, I know. They are winner, all they are winner, but we have to select, at the end. And if you want to blame someone, you can select. You see, they are here. Not me or Dr. Awadallah. We are only calculating. Okay, but first of all, I would like that the first winner will get a free registration for the next year and ticket and accommodation for the next year in addition to a trophy. Second winner, it will have an accommodation, also free registration, and also trophy. The other, they are going also to get all of them trophy because they participate in addition to free registration. So they are all winner, but little bit differentiated. And this is just, and all they are, it is, and this one, they will pay for us for this one. Those they are moderating, they have to pay for us because they compensate us for the next year. So the first one, where is it? I want to see. Lubna is the first one. Thank you. مرحبا الله يسلمك تسلمي. لا وعشان الجائزة عشان تأكد الناس عشان توجه. Okay, the next. Okay. The next winner it will be دكتورة نجلاء. دكتورة نجلاء. دكتورة نجلاء. على دكتورة. The others, by the way, the difference only points, يعني 0 something, it's not a big, 7.1, 7.2 like this. So it's very close. You all have done a great job. Thank you very much. And all of them, they will get a trophy. Outside, we'll give it in the there.
And I just want to say one thing. All the presenters were excellent. And believe me, the differences was very, very, very little. Those who did not have probably being the first or the second, don't be angry. Your presentations were very great. Thank you very much.
We'll take a photo.
We will take the photo. Okay, come, please, all very fast. Keep it down there.